song. So anyway, thank you for joining us today. This is our first grand rounds here at the Armory. Here's why we're doing it, basically. There's a lot of things we do here that are sort of different than what's done in traditional medical practices and the way we're blending fitness and medicine. There's some unique nuances, and I know that for us to do this at a good level, at a very high level, and to be able to change the way medicine's practiced, we need to have an educational piece, a scholarly academic piece as part of that. So over the next few weeks, we're gonna have one of these every week, every Wednesday. We're gonna have different presenters come in. A lot of them will be staff members here. We'll bring out some outsiders. Some of them will be fitness topics. Some of them will be medicine topics. Sometimes they might be neither one. So I decided to talk about performance-enhancing drugs today. Two reasons. One, I thought it was kind of an interesting topic, and maybe start with something that's not quite as boring as some other things. The other reason is we see a lot of this at the Armory. You know, it wasn't something as a physician I expected to see a lot of, but as our practice has kind of morphed, I sort of realized how prevalent this is, how common it is amongst the general public, and I feel like people who partake in taking performance-enhancing substances need help, they need guidance. A lot of times medical professionals aren't equipped to do that because they don't have the knowledge. We do. So I just thought, you know, we ought to be able to do our best to help out everyone that walks through our doors. So I kind of made too many slides, so I'm gonna kind of try to hustle through them. We may not get through them all, that's okay. The video from this will be on YouTube, so you can watch it later if you ever wanted to. All the slide deck's gonna be available too online. We're gonna eventually mass it into an Armory curriculum, you know, so I'm hoping to have about 100 topics, rotate through them every 2 years, you get to hit all the topics. So that's the plan. So anyway, so here's the issue. What's a performance-enhancing drug? It's basically an illicit substance that's used by athletes and individuals to help either increase their athletic performance or to change their physical appearance. These are just some statistics from different studies, give us an idea of how significant it is. Somewhere around 3 to 4 million Americans are using performance-enhancing drugs and anabolic steroids, according to one estimate. One study said that estimates 3.3% of high school students have admitted to using anabolic steroids. And another study said 5 to 11% of teens said they've used either synthetic HGH or steroids without a prescription. So it's more common than we think. So, you know, basically why are we talking about this? Well, you know, kind of I touched on before, like there's a lot of people in the public using these kind of substances. Among casual gym goers, it's really common, way more common than I thought. They need a place where they can turn to and trust, get good advice, help them from hurting themselves. And just because a lot of times in medical training, you don't get any background in it, we're a really good resource, and we can help people out, change a lot of lives, help sort of stop the spread of misinformation about these type of things. So that's why I think we need to be knowledgeable about this and be willing to talk to people when they come to us with that. So let's talk about the different types of PEDs. Basically, I like to break them into either two categories, either hormones, things that are hormones, or they're synthetically generated hormones that are, you know, basically analogs of existing hormones, or things that work on hormonal pathways. I love those as the hormonal drugs. And then we have non-hormonal drugs. Some of them are prescription, some of them are over-the-counter. Just if you say, okay, what's an over-the-counter performance-enhancing drug? Caffeine, creatine, right? Those are both performance enhancers. Those are legal, you know, so I wouldn't necessarily call them a PED, but yeah, that's essentially what an over-the-counter concoction might look like. I'm gonna start with hormones because hormones are basically the biggest category of PEDs. Those are the things we're going to most commonly see. And I think before we talk about hormonal PEDs, I think it's good to know what a hormone is. So basically hormones there's about 75 hormones in the human body that we know of. There's probably more than that, but they're basically made by glands, endocrine glands. You know, some of these here, the pituitary, thyroid, pancreas, adrenals, testes, ovaries. So they make these molecules, they travel to distant organs where they exert their effects, basically. And they're really powerful. Pretty much all our metabolic processes in the entire body are controlled by hormones. You can break them down into 4 big classes. Ones that are basically amino acids that are slightly changed to perform a function. Peptides, which are several amino acids strung together, maybe up to 100, proteins, which have a ton of amino acids, and then steroid hormones, which are based off of a cholesterol ring, essentially, and modified. And we'll kind of go through this, just so you have a little better idea what I'm talking about here, hopefully. And feel free to stop me and ask questions if anyone wants to at any point in time. This is kind of showing the difference between the different types. Like if you look at an amino acid base, they're either based off of tyrosine or tryptophan. So if you look at melatonin, it looks like basically a tryptophan molecule. It's been slightly modified that makes it melatonin. Epinephrine is basically a tyrosine molecule. And but you see it's kind of a small molecule, right? Then you go to the peptides. Each one of these are amino acids. So like oxytocin, for example, has 1, 2, 3, 4, 5, 6, 7, about 9 amino acids that you put together to make oxytocin, right? So you start to get to more complex ones. And if you look at like human growth hormone, it's hundreds of amino acids that are basically strung together to make that. In steroids, it's a little bit different. It has these 4 rings that are connected together. That's basically a steroid ring, which is very similar to the cholesterol molecule. So if you look at these, we have both naturally occurring hormones and then synthetic ones that we've made that are used. So we'll get into some of the details here in a little bit. I have a table of some common hormones in the body, right? There's about 75. I think I have over these next 2 slides, 20 or 30 of them. More information than we really need to know, probably most of us, but the main thing is to look at some of the main categories. You've got the ones that are involved with like glucose and energy metabolism. So you've got things like insulin and glucagon, and recently we've been talking about GLP-1 and ghrelin and leptin, right? And we've got the sex and reproduction hormones like the FSH, the LHs, the prolactins, the testosterones. We've got some that are involved with cellular growth, cellular regeneration, like growth hormone, IGF-1, erythropoietin. Some are involved with like cellular metabolism, like the thyroid hormones, TSH, T4, T3. We have the stress and mood hormones. Like these I always find interesting. Like some of these are fight or flight. Like you're walking through a woods, a bear jumps out at you. Your body has to respond, so it dumps epinephrine, and it dumps norepinephrine, and it dumps dopamine and cortisol, so you can like fight that bear off or run. But those hormones are also involved with like our moods, and cortisol being that stress hormone, is involved with inflammation in the body and also blood sugar regulation. We have like melanocyte stimulating hormone involves the skin, and that's how we tan. And the reason I brought this up is some of the newer peptides work off of that, so I think we need to know a little bit about that. Melatonin, which is involved with circadian rhythms, sleep-wake cycles, things like that. You've got parathyroid and vitamin D, which are involved with bone and calcium metabolism. Actually, vitamin D is actually a hormone. It's the only vitamin that I know of that's an actual hormone. We don't think of it that way, but they control parathyroid hormone and calcium and vitamin D, basically control our absorption of calcium, the storage of calcium in bone, and also the reabsorption of calcium from the kidneys, but also help maintain a steady state calcium blood level. And then you've got some that are involved with like fluid balance and blood pressure, things like angiotensin, antidiuretic hormone, aldosterone. Angiotensin, we think about some of the blood pressure medicines, the ACE inhibitors, angiotensin receptor blockers that work on modulating angiotensin. So let's talk about steroid. I think this is really important. So like I run across some people, whenever they think of steroid, their mind immediately goes anabolic steroid, anabolic steroid, anabolic steroid, right? Well, if you look at all the hormones in our body, we got 75 hormones, 12 of those are steroid hormones. And of those 12, only 2 of those steroid hormones are actually anabolic, right? Testosterone and dihydrotestosterone. A little bit progesterone, maybe a little bit DHEA, but they're very weak. So, I want when the word steroid comes up to not immediately go to that, because, there are 10 other hormones. You got the cortisol and all those kind of things that aren't anabolic steroids. And really, to me, testosterone, dihydrotestosterone are only really anabolic steroids when you take them at much higher doses than what is normal physiological dose, which we'll get into in a minute here. I just wanted to pop this up real fast. This is how steroid hormones are made. You start with a cholesterol molecule, and if you look at the actual genesis chart, it's really big. It's really, really complicated. I tried to simplify this as much as I could, but basically, cholesterol can be transformed into pregnenolone, which can turn into cortisol, or it can go to testosterone or progesterone, right? And then progesterone can be turned into aldosterone, right? But here's some of the ones we see a lot. Testosterone is converted to estradiol in our bodies by an enzyme called aromatase, right? So that's the sort of hormone that sometimes we block with like Arimidex in order to decrease the amount of estrogen estradiol that's produced from testosterone in our patients. Or it can be converted to dihydrotestosterone by an enzyme called 5-alpha reductase. That's the one we block with like finasteride. So anyway, that's kind of like the steroid synthesis pathways. Okay, this is what I want to cover today. So we've got some hormonal PEDs, we've got non-hormonal PEDs. So we'll kind of work through it. Mostly what we're going to see in our practice is going to be like number one, we're going to see a fair amount of that. We're going to see a little bit of number two, the SARMs. We use the SERMs in clinical practice a fair amount. And then so on and so forth, right? So hopefully I can get through everything. If not, we'll cover the most important ones. And we can talk about the other ones later. You can look through the slides later. Okay, let's talk about anabolic steroids, right? So there's two properties we really want to think about. You have the anabolic part of the steroid and the androgenic part of the steroid. The anabolic, basically anabolic means to build tissue, right? It can be building muscle, it can be building fat, it can be building bone. The opposite of anabolic is catabolic, right? That's when you lose tissue, whether it be muscle, bone, fat, right? So what really people who use these type of performance enhancing drugs are looking for the anabolic properties typically, right? They want to be big, they want to be fast, they want to be strong, they want that additional muscle mass from them. Most people don't want the androgenic part, and that's the part that's like the masculinizing part of it, right? It's the part of these molecules like testosterone, for example, that makes you grow a beard, makes you have chest hair, makes your voice get deep. If you're a woman who takes it too long, you need clitoral growth, clitoromegaly, so some of these type of things. So, you know, a lot of testosterone and dihydrotestosterone both have anabolic and androgenic effects, but when people and scientists over the years have tried to create different formulation of steroids, they're basically either taking DHT or testosterone, modifying to change the chemical effects, right? And a lot of that was trying to make them more anabolic and less androgenic, or to make them orally bioavailable so you don't have to inject them. So there's a concept of what's the ratio of different substances for their anabolic versus androgenic effect. And this initially came out, hey, we're going to make these compounds like Anavar, for example, Dianabol. Can we chemically modify them and make them stimulate the anabolic parts of the receptor, but not the androgenic parts? And they did some studies on mice and rats, and they were weird studies. They were looking like anal sphincter tone and a bunch of other weird stuff that doesn't really translate into humans. And they initially said, yeah, you can kind of separate those effects. Well, later, we're not so sure now that that applies to human beings in the same way it does to animals, although some of the research recently shows that maybe it can, maybe it can't. So sometimes when someone's saying, hey, I'm a woman, I'm taking Anavar, for example, because it's less androgenic, well, that may be true, it may not be true, you know? So that's, okay, so here's how testosterone, dihydrotestosterone molecules are commonly modified into the synthetic versions that we run into contact with, right? So there's really four common things we do. You can either alkylate it with a 17-alpha group, and these are the ones that makes it orally bioavailable, right? So pretty much all of the oral anabolic steroids are gonna be 17-alkylated. So yeah, it works. Like if you swallow testosterone, it doesn't hit your bloodstream. It gets broken down before it hits your bloodstream. But if you change it to like a methyl testosterone, you can orally take it and it will get in your bloodstream. The problem is those alkylated versions are really, really hard on your liver. Sometimes these other next two things, the 19-demethylation, is an attempt to increase the anabolic effects while you decrease the androgenic effects, right? So some examples of things that have been 19-demethylated would be like nandrolone, which is DECA. They can 5-alpha reduce them, which actually enhances the androgenic part relative to the anabolic part. So like an example of that would be Anadrol. what we use more often is this 3-beta and 17-beta esterification. That's trying to increase the half-life. So testosterone cypionate, which is what we use, it's been modified in that way so that you can inject it once a week instead of every day, right? Undecanoate, another formulation of testosterone, maybe you can inject every month. If you do something like propionate, you're gonna have to inject it every few days. So that's what the purpose of those are, to increase the half-life on things so that you don't have to administer it quite as frequently. Run down a quick list of steroid names you might hear, right? Come across. So the top, above the line, are things that are available injection route. Below the line are oral. So you've got trenbolone sandwich, people call it, right? People like it because they feel like they're getting a ton of effects, but the side effect profile is really, really bad. It's really harsh. If you talk to someone who's taken it, they can attest to that. You've got decadrabalin, which is nandrolone, which was kind of an OG. Equipoise, which is boldenone. So the thing that I find interesting about that is the word equa in the front of it actually is equine, because it's a veterinary drug, right? So, and people that have brought this into our office and shown us, there's usually an animal on the box. Sometimes it's a dog, sometimes it's a horse, but you're basically injecting animal products in their own bodies. Sustanon, you'll hear a lot. It's a mix of different testosterone esters. It might have propionate in it, it might have enanthate in it, it might have undecanoate in it. I think the people who use that are hoping to have like a flatter curve when they take it. Some of these actually have clinical indications, right? So, like for example, Sustanon's approved for osteoporosis and HIV/AIDS wasting syndromes. Winstrol, which is the thing that used to talk about racehorses taking that made them really, really veiny. You can take orally or inject it, but it has an indication for hereditary angioedema. I've never seen a patient with that, but apparently if you have a patient with that, you can use Winstrol for it. Anavar we see a lot of. Female bodybuilders especially, they're like, yeah, I just want to take this before my show, but I don't want to have a lot of the masculinizing side effects, so take that. Dianabol, it's a bulking agent. It's really hard on the liver. Anadrol has a clinical indication for Turner syndrome, which is a genetic disorder, chromosomal disorder. They use it for recovery from severe burns or bone pain from osteoporosis. It's indicated for that. Methyltestosterone, actually, when I've been over at Tremont, they stock it on the shelves because some gynecologists or other physicians still prescribe that to sort of treat testosterone deficiency or low sex drive in women. And then some other things you might hear: Primobolan, Provira, and Halotestin. Just basically want everyone to be kind of familiar with the names in case they pop up. Okay, so let's talk about his testosterone and anabolic steroid. Here's my opinion on it. If you're taking it at a physiologic dose, no. If you're taking more than you're supposed to for basically performance enhancement, then it probably is. So here's I want to talk about this a little bit. So we use LabCorp for our labs. If you order a total testosterone level in men, the normal range for that's 264 to 916. Really big range in my opinion, right? Like that's a really big range. There's a big difference between someone who has a testosterone of 270 and someone who has a testosterone of 870. For women, it's 4 to 50. Like that would be, you know, Rebecca or Meredith, they could be sitting around a 40 or a 20 or whatever. That's a normal women's range. If you look, you know, it's maybe somewhere 1/20th of a male, something like that, 1/12th, 1/16th of a male's. So if you take doses that increase your blood level past those ranges, then it's probably a performance enhancing drug. And it probably could be considered an anabolic steroid in those contexts, right? Just as a note, for women to have adverse side effects from it, they probably need a blood value somewhere around 150 or higher for an extended period of time. So, you know, sometimes we'll see people, some women come into our clinic who have had testosterone pellets implanted for hormone replacement, and we'll check their level, and they got a level like 400 or 500. And to me, that's really scary because those pellets get in your body for a long time, and you can start to have some of those effects that maybe are not intended. So, because those side effects sneak up on you really slowly. It's like all of a sudden they're there, and once they're there, oftentimes they're not reversible. Okay, just a quick thing about testosterone dosing. This is normal testosterone replacement dosing in men and women. Most guys, we usually use testosterone cypionate. It's because we can get it really easily. It's safe. It's not super expensive. You can use once a week dosing in men, twice a month dosing in women. Most people, 200 is a good dose. Some people need a less, some people need a little more. But the purpose of this is to kind of, like most people are, I would say 100 to 300 would be a really broad range for what people need. But people who abuse it are taking 500. Sometimes they're taking 1,000. Sometimes they're taking that 1,000 testosterone, plus they're taking Tren and Anavar and Dianabol on top of it. So they're getting really, really high blood levels of these type of things, right? So for women, a normal dose is about 25 milligrams every other week. So it's about 1/16 of the male dose. Okay, I want to spend a little time on this because I talk to people a lot about this, patients that come in, and I'm like trying to talk them out of not hurting themselves, right? And here's the key here. This is a serum testosterone level, and this little yellow range is sort of like what a normal physiological level is in a man, right? Say from 350 to 900. The green are the benefits that you receive from this medicine, right? Like, and if you look, like if you go from 0 up into the physiological range on the green chart, improvements, benefit, benefit, benefit. Okay, now you take a little more than 900, you get some more benefits. But as you can see, somewhere around 1,800, 2,000, 2,200, that curve flattens out. It doesn't matter how much you take after that. You're pretty much maximizing the benefits you're going to get from this. Now, the reason it's important is I want you to look at the risk curve, the red curve. This is how you could be hurting yourself by taking it. And really, it's pretty flat in the normal range. You get above the normal range and it starts to go up, but then it becomes exponential, right? So, you know, if you look here and you say, hey, like at a dose of 900, like that's my benefit to risk ratio. And someone says, hey, I'm going to take some chances because I really want to make these gains for whatever reason in their mind. They want to make it, and you say, okay, if I creep the dose up a little bit, yeah, I'm taking more risk. I'm taking more risk, taking more risk. Somewhere around 1,800, right? Like that really changes. So you might have gotten, going from say 900 to say 1,800, you might have gotten 10, 25% more benefits, but 3 times the risk, right? Now you look at someone who's taking 1,000, stacking it, and they're getting the level of 3,500 or 5,000. They're not really getting a ton more benefits, but they're getting 100 times the risk, you know? So that's my point. Like you don't, like if you're gonna be a knucklehead, right? And you're gonna hurt yourself, just don't be a real knucklehead, right? Like don't take that dose. Like that's really gonna hurt you. And you know, as a medical provider, I would never recommend taking more than the physiological dose, you know, but I think it's important to educate people about that because they sometimes don't understand. Like people, it's always more is better sometimes, and sometimes we just have to tamper that down. Let's run through some of the risks of anabolic steroids. Basically, testosterone stimulates your blood, and testosterone-like substances stimulate your blood marrow to make more red blood cells, right? So your hemoglobin goes up. That's called erythrocytosis, if your hemoglobin goes beyond the normal range. So in some ways, having a really high hemoglobin is good if you're an endurance athlete, right? You can carry more oxygen, you can go harder, you can go faster, you can go longer, right? Like that's why these cyclists and some of these triathletes over the years have tried to get really high hemoglobin levels. The problem is your blood gets thick and sluggish as you increase that hemoglobin. And the blood vessels in our brain are small. So if it gets too thick, you put yourself at risk for strokes from that, right? And people who are more likely to get polycythemic from it are people who have can't ventilate well anyway. Maybe they have a really big chest cavity, maybe they have sleep apnea, maybe they smoke. You can get heart enlargement, elevated blood pressure, and increased risk of premature heart attack and stroke. We've actually seen in our clinic, I think we've seen someone as young as 29 that had a heart attack related to basically anabolic steroid abuse. We've seen people in their early 30s go into atrial fibrillation, you know, so it's gonna make your lipid panels look worse. It's gonna basically increase your LDL, but we really see the HDL plummets. You know, a lot of times we'll see an HDL of 12, HDL of 18, especially people who are taking oral agents. The liver part of it, it's mostly gonna be with the oral agents. But if you see someone who's been running an oral agent for too long, they'll come in with their LFTs easily in the several hundreds or higher. If you abuse these for a long time, and I've seen maybe twice in my career, I've seen an ultrasound or a CT or an MRI where your liver becomes full of these little bloody cysts, right? It's completely full of bloody cysts. It's called pieliosis hepatis. That's someone who's been taking it for a long time, you know. Gynecomastia, elevated testosterone, more estrogen, get breast tissue, right? If you, initially when it first starts to happen, you can treat it and slow that progression, but if you've had it for too long, there's too much breast tissue, you basically have to have a mastectomy or some kind of procedure to take that out. In females, we already talked about this, deepening of the voice, Adam's apple, beard, chest growth, clitoromegaly, which most of those outside of the hair, the hair growth, you can have it removed with a laser, but all those other things are not going away. Let's talk about mood changes, because I get this question a lot with testosterone therapy. Is it going to affect my mood? So what I find from mood, it's either the fluctuation of doses, like a traditional steroid cycle, where you would start off, maybe not someone's never taken it before, they have testosterone level of 600. They do a 16-week cycle with a bunch of stuff that gets them an equivalent level of 5,000, and then they ramp down, go off it, now their testosterone level is 80, right? Like that tends to cause a lot of mood changes. So the changes to some extent and levels can cause mood changes, but if you get a really high value too, it can affect your moods. Same thing with can increase hair loss, increase prostate growth. If you're taking an anabolic agent, it's going to decrease sperm count because it's going to suppress the pituitary. All of a sudden, the pituitary and the hypothalamus say, hey, plenty of testosterone in the system, we don't got to make any. So they don't send the signal to the testicles to make some, so basically the testicles shrink down, The Leydig cells and the Sertoli cells don't have to be activated for a period of time. Thrombosis, basically, if you're taking too much stuff, it increases your risk of blood clotting and strokes, basically like pulmonary embolism, skin changes. Some people get psychological dependence too. I've seen this a fair amount. And the thing is, when people are taking these substances, they feel almost superhuman, right? Every lift, they get stronger, they get bigger, they're leaner, right? And when you go off of that, especially if you go completely off it and your level bottoms out, that's all gone, right? So it starts to mess with people's head, and they can sometimes get this need to stay on it so they can be where they once were. Okay, move on from anabolic steroids to SARMs, right? Like we've seen a fair amount, Rebecca, I know we've seen some SARMs in our practice, and Sarah, right? So here's what SARMs are. And a lot of the big pharma companies were investigating making these molecules. So they bind to the androgen receptor. You can get a lot of the same effects as testosterone or other anabolic steroids, but when they made them, they thought that they would be safer, right? For example, maybe one of their theories was we can make these and it's not going to be turned into estradiol, or we can make it completely do anabolic effects without androgenic effects, or maybe you take it and suppresses your fertility less. Well, pretty much any study they did on these, they stopped early because they weren't getting the results they wanted, right? So they kind of killed all the studies. Bottom line was none of them had ever been approved for human usage because of a study that showed good results. Basically as of 2023, no SARM had ever been approved by the US FDA for human use, despite having lots of trials. And basically they've been banned by the World Anti-Doping Agency since 2008. You can get them really easy on the internet, right? For example, you just go to US SARMs. I got the link right here. You go to ussarms.com. They're all there. You put it in the cart, you buy the thing, they send it to your house, right? These are the most common ones that you see, ostranine and ligandrol and testolone and andarine, right? So they come to their house, and here's what we see in our practice. You see a sophomore at OSU, right? And dude just wants to be more jacked, wants girls to like him, whatever his goals are. So he's like, hey, I think this is safe. I read on the internet this is safe. I saw some guy talking about it's safe. They buy this medicine, right? They take it. Well, then they come into our office because they're messed up. And what we've seen actually, you guys can tell if it's the same thing too, like we've had some young people that went on this for relatively short periods of time. I'm talking 3 months or something. And their testosterone levels after a year did not really come back, like really, really low, right? To me, I just noticed more of that HPT, hypothalamus pituitary testosterone axis suppression than with anabolic steroids, to be honest with you. And that was the exact same thing these were marketed for, So I mean, that's to me what makes these the most dangerous is because you can really easily get them. There's not much information about it, and the information is that theirs offering is a safer alternative when, in fact, I kind of think they're more dangerous, to be honest with you. Okay, these are some things that we use in our practice, but people also take on the street, right? So SERMs, as opposed to a SARM, which is a selective androgen receptor modulator, these are selective estrogen receptor modulators, right? And they have some interesting uses, like tamoxifen, which we use in breast cancer patients. It basically binds estrogen receptors. and it prevents estradiol from binding to them, so they're not turned on, right? So even though you could, with something like tamoxifen, you could have a really high blood estradiol level, it can't do anything because it can't get to the receptor, to make any effects. And you'll see bodybuilders take this, and sometimes we use it to help people who have had side effects from taking drugs or other things like that. Clomid is actually also a SERM, and it binds to the estrogen receptors in our brains, both male and female, and it tells them to make LH and FSH, right? So in women, that LH and FSH goes down and tells you to ovulate, so then you can, help with fertility. For guys, that LH goes down to your testicles and tells you to make more testosterone. The FSH goes down your testicles and tell the cells to make more sperm, right? So you can use Clomid to enhance, basically increase your testosterone levels. What we find though with and same thing, HCG is very similar. The difference being Clomid stimulates your pituitary to make LH and FSH. HCG, the molecule looks like LH and FSH, so it binds your testicles or your ovaries, right? And they think it's LH and FSH, so you get the same results. Now, HCG is actually something that we produce in our bodies. Women do when they get pregnant, right? That's the basis of the home pregnancy test. Because as soon as a woman gets pregnant, they make HCG. The amount they make is proportional to how long they're in the pregnancy. So so basically when they initially were trying to get HCG, they would collect urine from pregnant women or basically from pregnant animals and filter down to get the HCG out and then re-administer it, right? Now we use synthetically made versions, but with HCG and Clomid, when you give them to a male, for example, you can stimulate the testosterone levels, but they tend to not get really high. They tend to not get above physiological range. So when people take these as part of a PED program, it's when they go off the other steroids, they take those so that their own production kicks back in and they don't have that huge trough for a while. Aromatase inhibitors block aromatase and prevents testosterone or other anabolic steroids from being converted to estrogen. So a lot of times people will take that so they don't get those estrogenizing side effects from anabolic steroids. Let's talk about growth hormone a little bit, right? Because this is kind of a fun thing. So a couple things here, people think growth hormone is pretty amazing, right? They think hey, if I get on growth hormone, I'm gonna be shredded and veiny, I'm gonna be big, and my tendons will be indestructible and all this kind of stuff, right? And growth hormone does kind of do some of those things, but if you take it for a long period of time, there are a lot of things that happen, right? There's a clinical condition called acromegaly, where people get a tumor, could be in their pituitary or elsewhere, that causes them to make too much growth hormone, right? So if someone were to take growth hormone at a high dose for a long time, it's kind of giving yourself acromegaly. So here's this woman here, her name's Marianne Webster. She was a nurse, right, in London, and she had acromegaly. And you can just see the dramatic effects that it had on her, right? So what it does is, it does cause your muscles to grow, but some of your bones and some of your soft tissues and cartilage grow. So you get big ears, big nose, this part of your head grows, your jaw can grow, and then your teeth become widely spaced because your jaw is bigger. Your tongue grows, soft palate grows, right? It causes your fingers and toes to grow. It can cause basically the tendons in your wrist to grow, giving you carpal tunnel, or cause your heart to grow. Can cause your internal organs to grow. And growth hormone actually is a medicine, it's a hormone in our body that one of the things it does is also raise blood sugars too. So it can cause some issues. So yeah, it can cause a lot of problems. So for her, you can see the physical changes that it made on her. Now, Ronnie Coleman, he's the GOAT in my mind, right? 8-time Mr. Olympia, bone shredded, but a lot of the bodybuilders who were really taking that, their organs would grow and they would get organomegaly. So even though your bone is shredded, it would almost look like they had triplets in there, So that's, that's some of the side effects. So, and I think people don't really think about this, sometimes before they take it, how it can stack up and accumulate. Because a lot of the popular things that are out right now, even if they're not growth hormone, they are activating growth hormone. Some of the peptides we see, right? IGF-1, things like that we'll talk about are actually stimulating the growth hormone axis. So let's talk about some of these peptides. Every day, right? Someone comes in, tell me about BPC-157 or all these other things. So what are these investigational peptides? Well, they're investigational, right? Basically, the concept is any chemist who has some basic knowledge, can put amino acids together in chains, anywhere from two amino acids to 100 amino acids. Like for comparison, insulin has 51 amino acids, and it was the first hormone created in the lab, right? So they're putting these things together and saying, okay, what does this do, right? Which is really interesting. And there's research on it, but there's not really research on humans. Like there's studies on rats or mice or this, that, or the other, and a lot of studies aren't necessarily like, let's take a human being and see if it makes, well, his knee, heal faster after surgery, right? They're like, let's give it in rats and see what happens to them and then extrapolate it. So you don't really know if any of these peptides actually work, and you also don't necessarily know the safety profile because they haven't been tested in basically humans. So we're kind of making some assumptions on these lines. And the thing about these is you can go to a place like extremepeptides.com. There's a whole bunch of sites out there, see it, $75, put it in your cart. They'll have you check a box that says these are for research purposes only, these aren't for human consumption, and then they mail it to your house. So they're really easily available, right? And there's a lot of people are excited about these things, right? And I kind of am too, because they have some really cool potential. Just as a physician, I feel like people look to me, to us, right, and ask questions. I don't ever want to hurt someone, So for me to recommend something, I need to know that's been studied and that it's going to be safe and that's efficacious, and also that the supply chain is good. Like I don't necessarily know that Extreme Peptides is sending me BPC-157 or something else. They might be, right? They might show you a mass spectrometry report, which looks really good, but the problem is there's not like a certifying body that's coming in and inspecting their labs and holding them to standards, So those are some of the problems with this. And and I get it, people are interested, they'll take risks, they'll put things in their body, which for me, it's just as long as you know those risks and you make educated decisions. But as a physician, I find it hard to recommend things that I don't know are safe or effective. Let's talk about a few of the peptides. So BPC-157 is the one we get the most comments about. And people have taken it are like, yeah, it heals soft tissue injuries. It healed my tendons. It healed my cartilage. It healed my muscles. They've also been looking at for stomach ulcers and inflammatory bowel disease and a bunch of other things. But the studies on rodents say that they might help, right? But unfortunately, there's not really any studies in human that we can, go to PubMed and you can search it all day and you're probably not going to find a human study on it. So that's kind of the background with BPC-157. Most of the other things, you'll get questions about this all the time, right? And here's most of the other agents that are out there look like growth hormone releasing hormone. That's made in your hypothalamus, goes your pituitary, tells your pituitary to make growth hormone. So all these things are trying to get your pituitary to basically secrete more growth hormone, which then causes your body's tissues to make IGF-1, growth hormone and IGF-1 float around in your bloodstream, cause the effect. So a lot of these here you might see, the sermorelins, ipamorelin, tesamorelin, hexarelin, CJC1295, those are basically growth hormone releasing hormone analogs. And so is AOD 9604, it's a growth hormone analog as opposed to a growth hormone releasing hormone analog. Bottom line is looking for the same effect, which is more growth hormone and IGF-1 in your body. Slight change of direction here. So you've got, these are some other things that are popping up on the peptide website. So like melanotan and this PT141. So these bind to these melanocortin receptors. There's like several of them, MCR1, 2, 3, 4, 5, whatever. But really what those things do are involved with tanning of your skin. You're exposed to sun, your body releases MSH, melanocyte stimulating hormone, goes to your skin, causes it to tan, right? So basically these hormones stimulate that and can make you have a suntan without going out in the sun. They're also seem to make people really horny, especially women, and can increase your sexual function, right? So they're really interested from that. Now, basically, sometimes though they cause pigment changes that you don't want and cause increased mole formation. So we actually had a pretty interesting, one of our patients who has a rare condition. It's called hereditary erythropoietic porphyria, kind of a rare genetic condition. This guy, nice guy, a little bit younger than me, but if he went out in the sun at all, it would cause a reaction that caused excruciating pain. Like and he had kids that played baseball, so he would either have to be covered head to toe to go experience those things, and it was really hindering his quality of life. Well, in Europe, their MSH is approved to treat this, not in the US. He couldn't get it in the US. So he was talking about, do I go to Europe, fly there, pay for the drug, get it administered, come back to help me with quality of life. It was going to cost him something like $20,000 or $30,000 to do that, and he was willing to do it. And he said, hey, I know I can get this from Extreme Peptides. And I was like, well, I don't know, dude. I don't know if that's what it is, but if you want to try it, hey, we can see what happens. It worked for him. He ended up spending $100 from Extreme Peptides, got the thing. We kind of helped him dose it, and it worked. He didn't have any side effects, and he could go to his kids' baseball games and be happy. So it's kind of balancing that, unknown risk of things versus potential benefit, on a case-by-case basis, and just talking through it. It's kind of how I look at it. I've also seen this thymosin beta-4, and it's kind of tissue repair and wound healing. People talk about scars. I see it marketed towards women a lot who are like, have this beautiful, healthy skin, and all that kind of stuff too. Same thing, maybe it works, maybe it doesn't. I just don't know for sure, So, okay, let's talk about insulin. Change gears here. Some bodybuilders, some athletes take insulin. Insulin is actually probably the most anabolic hormone in the human body. Insulin is what makes you gain weight, right? But it's non-discriminatory. You're going to add a lot of fat, even if you might add some muscle to it. So the concept of insulin is if we go eat a bunch of carbohydrates, our body can sense how many carbs we ate. It can roughly exactly tell our pancreas how many units of insulin to release to cover that carb load, right? So you maintain steady state blood sugar. Over time, if you eat a lot of sugar, a lot of carbohydrates, your insulin levels are really high, you accumulate weight, right? That's insulin. So bodybuilders are thought being, hey, I'm gonna go get a crazy workout in, right? And then I'm gonna eat a bunch of carbs and I'm gonna shoot up with some insulin afterwards because this insulin spike's gonna make me really big. Well, here's my problem with the logic. One, I think if you ate that same carb load anyway, your pancreas is going to know how much to secrete, and it's going to secrete that much insulin anyway, right? And what you're injecting in your body is just now your pancreas isn't making it. You're taking it exogenously. The other problem is you can't accurately figure out how much you need, and if you take too much, your insulin levels go too low, right? In bodybuilder mentality, more is better. I start off with 10 units, go up to 20, go up to 50. Next thing you know, you're in basically you've shot your blood sugar down to 20 and you're in a lot of trouble. So I actually have a personal story of this. There's a guy who's a good friend of mine. His name is Big Tony, right? Big Tony, this is probably 20 years ago now. Knew him from the gym. Big Tony's 5'9", he's 275. He's the biggest, strongest motherfucker in the gym. He's, awesome dude. So Big Tony also had some psychological issues related to his body. He thought he was really small, right? And Big Tony would walk into the gym, and if a 130-pound dude walked up to him and said, hey, Tony, how you doing? You're looking a little small today. Big Tony would turn around and leave and go cry, right? Because, he's having some issues related to this. Well, Big Tony would shoot up with insulin, and he actually turned into a patient over time and developed renal failure from some other things. But anyway, he died at like 29 because he shot up too much insulin, dropped too low, and he was one of my favorite people. It was really sad, So anyway, I hate to see people do that to themselves. Talk about thyroid hormones a little bit. So you see some athletes, they're like, hey, I got some T4, I got some T3 or whatever. The thought being speed up your metabolism, burn fat, get shredded. Problem with that is if you're hyperthyroid, you burn a ton of muscle too, and you lose bone mass. And you can have arrhythmias like atrial fibrillation. So from my standpoint is I get what you're trying to accomplish, but I think you're going to find out that you're going to burn just as much muscle mass as you did while losing bone mass too and putting yourself at some risk. So I'm not a big fan of that, as a way to get shredded. Let's talk about erythropoietin or Epogen. The cyclists, they call it EPO, right? They're obsessed with EPO. They want to have hemoglobins through the roof, right? So what erythropoietin is, it's a hormone made in our kidneys. So our kidneys sense how many red blood cells are in our bloodstream. If it gets low, produces EPO. EPO goes to your bone marrow and causes you to make more red blood cells, right? So this hormone was synthetically made for people with renal failure, because when you go through renal failure, you can't make erythropoietin, and those patients get anemic. So instead of giving renal failure patients chronic transfusion, they came up with giving them recombinant erythropoietin, and it worked great, right? So now, us being human beings and doing what we do, we said, hey, let's give ourselves erythropoietin, make our red blood cells high, and I'm gonna go conquer the world of basically aerobic competition. So, but it's the same thing with testosterone. Too big a hemoglobin clogs the small blood vessels. So there's some risk involved with that. We don't see a whole lot of that here. I mean, personally, I don't have a ton of endurance athletes yet. Hopefully we'll get some more coming in through here. Glucocorticoids, right? So this is something else that athletes sometimes use, sometimes abuse, not as common as some of the other things, but basically glucocorticoids are like cortisol in our body, right? And then there's synthetic versions that we use clinically, and we use dexamethasone, right? We use prednisone, we use Solumedrol, just synthetic versions of cortisol. So you can give them in shots. Sometimes we'll give them intra-articularly in someone who's got a banged up shoulder, banged up knee, and it might knock out the inflammation, decrease the pain in that joint, and be useful for certain things, but they sometimes can actually weaken the joint or cause damage to that joint. So I think they should be used cautiously, and as maybe later term choices for those type of things. But we also sometimes give them for someone who's got asthma that's out of control, or a bad rash, or used for some type of cancers or autoimmune disorders to modulate the inflammation. So here's the thing. And this happened to me one time because I had really, really, really bad poison ivy, covered my head to toe. And I was training for marathon, so I had a 17-mile run the next day. So I gave myself 8 milligrams of intramuscular dexamethasone, so like poison ivy wouldn't kill me. I felt bulletproof, like energy for days. I had not a pain in the world. My joints didn't hurt at all, right? So like you could see the benefit if someone's got a big event coming up or a marathon, like, hey, maybe I'll take 80 milligrams of prednisone the day before or something. So, I don't see that a ton, but we might run into that. Problem with, if you use it a one-time dose or something like that, not too many long-term effects, but when we use glucocorticoids at significant levels for periods of time, weeks, months, years, the side effects are really bad. It causes muscle mass loss, fat accumulation, messes up your bones, get osteoporosis, basically can mess up your sugar metabolism, give you diabetes, things like that. GLP-1 inhibitors, I haven't seen a ton of this in the world of bodybuilding. I think we will because they work really, really well, right? But the concept of GLP-1 inhibitors, and this is the semaglutides and the tirzepatides, which probably will be a topic of another lecture. Basically, they can work on ghrelin and leptin in your body, which modify feeling full versus feeling hungry. Some thought that it can help regulate your body's set point for body weight. So people who have been heavy for a while and their set point's too high, it can help reset that and lose body weight. But, it's also really good at losing visceral adipose tissue. There's a lot of good things going on here, but I would be surprised if you don't see bodybuilders, using this to help them lean out before shows. Let's kind of run through some non-hormonal PEDs. Everything we talked about were hormones or worked on hormonal axes. Stimulants, see the Adderalls and the Ritalins and the ephedrins, just because it amps you up, right? You're ready to go. You're more focused, perhaps. But also sometimes people use them for weight loss, stimulates your metabolism, heart rate, things like that. Diuretics, I see this in bodybuilders a fair amount. Like, will do these cycles, right? And they step on stage and they have to look a certain way, so they'll take Lasix to pull off all their body fluids. They look really striated and veiny. Problem is it causes you to get rid of potassium and magnesium, and they often don't, replace that correctly. So more than once, someone's been taken by squad to the hospital from the Arnold Classic because they took a bunch of Lasix, got on stage, started flexing, and just went into tetany, So you might see a little bit of that. Sometimes they'll take things like probenecid because they might mask being detected in their blood or urine. Some other things they might use, sometimes use cannabinoids, marijuana, THC gummies, things like that. Sometimes they'll use opiates, right? Like, I really hurt, and if I take some oxycodone or some tramadol, I can get through my workout. To me, it seems like a really bad idea because you're injured and now you don't feel it, so you go injure it worse. Then you risk becoming addicted to it. Some sports will use beta blockers like metoprolol, like archery, for example. You have to be really steady. You can't shake, so those type of things can actually enhance your performance for events like that. Some people take beta agonists like clenbuterol, right? Clenbuterol is basically an asthma treatment. It's like albuterol, but people used to take that to cut because it would increase their heart rate, blood pressure, and increase their metabolism. Blood doping, let's just talk about blood doping real fast. Blood doping would be like, Bill comes to me and he's like, hey, I'm gonna run a marathon. I wanna kick ass. So you're gonna pull 3 pints of blood off me. We're gonna put them in bags, we're gonna store it in the fridge, and then before the event, we're gonna transfuse him with those 3 units of blood, so he's got all this blood, and he can go run faster. So that happens. Same risks of, having too much hemoglobin. Now, gene doping, I don't know that it's occurred yet, but the thought being you can actually implant genes in human beings to change their structure to perform better. I've never seen any documented cases of this, but I have no doubt that it will happen. So let's, real quickly, let's talk about some of the problems with PED usage. Well, legality. Most of these things are illegal. Truth is, they're not high on law enforcement's radar, right? Unless you're a huge distributor. But in theory, the people could get in legal trouble for taking this. Here's some of the biggest issues I have is the supply chain. You just don't know what you're getting. It doesn't matter how good you think your source is, right? Just a couple stories that I've seen in clinical practice. Probably most of you have heard these, but I'm going to tell them again because I like to tell them. But two different individuals that I've seen over the years. One was a very young female competitor, bodybuilding competitor. She was competing in the bikini division. She was early 20s, college gymnast that switched to bodybuilding. She was really good, really lean. As she was checking her blood sugars in dietetic school, her blood sugar was 280. She's like, what the hell? Do I have diabetes? How could I have diabetes? We tested her, you don't have diabetes, but she did in fact have a blood sugar 280. As we worked through it, she said, yeah, I'm taking Anavar. I'm taking Anavar from my coach, and my coach is really reputable. And I was like, well, I hear you. I don't think he had bad intent, but when we got those Anavar pills, sent them off to a lab, it was actually prednisone. So she was inadvertently putting prednisone in her body, which is causing the exact opposite of what she was hoping it to do, right? And I still don't think that her coach had ill intentions. I think he just got it from someone too. So my point of that is you just don't know what you're getting, even if you think you trust the source. Another one that I had this dude come into my office, and he had a big abscess in his thigh, and he looked like someone who might use steroids, right? And the thigh was right where, abscess was right where you inject it. And first I'm like, what happened? Spider bite. Okay, what really happened? Okay, so I injected myself with, I don't remember what it was, DECA. Let's call it DECA, right? I was like, okay, cool, interesting. I'm like cutting into him, draining this thing, talking. So tell me about your sterile technique. How do you inject it? And we kind of go through that. And I'm like, so where's your source? And he goes, well, actually, doc, I'm the source. He's like, I'm one of the biggest suppliers of anabolic steroids in Columbus. I was like, okay, interesting. So tell me how you make this stuff, right? He's like, well, I get a compounding kit from California, and I get the DECA powder from China, and I compound it in my house, right? And if you look at like the way you compound a drug, you gotta have these big sterile hoods, and everything's a very certain way, because if you put something in a bottle that someone injects, it cannot have any bacteria at all, right? So it's a very strict process you go through. He basically said, well, basically I took a couple bowls, I got some olive oil from Sam's, I mixed it with the powder, stirred it all up, put in my oven at 400 for an hour, and then I bottled it, right? And I was like, what the F? So then I'm like, did you use sterile stuff? He's like, no, I actually stirred it up with a spoon that I ate peanut butter with that morning, right? So like he had inoculated that entire batch with bacteria from his mouth and then distributed it to a lot of people in Columbus, right? So that's the supply chain risks that people take. Obviously most of these things have no clinical studies for efficacy, whether they work, and also safety. Most sports ban them, a lot of sports aren't tested or whatever, but some things are. And then people take ridiculously high doses. Some things that would be a little dangerous at a certain dose, people take 10 times that dose, making them really, really dangerous. And then they stack them together. And then there's no source of good information, right? They read something on the internet, on a blog, or some Instagram person has a bazillion followers who really doesn't know it, and they get bad advice, right? And they end up hurting themselves, and that's an issue. So, and the other thing too is just having good resources, being able to go talk to a physician, have your blood tested. Let's talk about it in a non-judgmental way. Like, so for me, it's like the conversation is, okay, not freak out. why the F are you doing that to yourself? It's, what's your goal? Like, you know, obviously, like, you know, you're putting some effort, you're taking some risk. What are you trying to accomplish? And like, one patient came in the practice last year, 28-year-old guy, IFBB pro, heavyweight, had potential, looked terrible, by the way, just acne everywhere. But he says, hey, doc, my goal is to win Mr. Olympia. And he said, if you could tell me I'd win Mr. Olympia tomorrow and die the next day, I'd say yes. And I'm like, okay, well, I hear you, and I respect, you know, your dedication to this, but, and that might be different than what I would be willing to take to accomplish the goal. But what if you could win Mr. Olympia and not die and have a normal lifespan, right? So with him, like if I would have just said, hey, stop taking all steroids, get the fuck out of my office, it's not going to change his life, right? He's going to keep doing it. But the conversation is like, over time, multiple conversations, understanding how dangerous it is, understanding that you can be safer about it, monitoring this person with the eventual goal of not taking those substances is, I think, helped his life. And we've had several people over the years who we've taken that approach, and it wasn't the first visit they stopped their ways. Sometimes it was a year and a half later, but just having someone they can trust, someone they can talk to, someone who hears them and can understand what they're going through, I think can be really, really helpful for some individuals. This is just for your links. If you want to click on those, give you a list of all the World Anti-Doping Agency banned substances. So also there's some references. So anyway, this is the last slide. Let's never lose sight of why we're here, right? We developed, this business is here to help other people, right? That's why each and every one of you here today decided to be part of the Armory team. Like, we care about people, we want to change their lives, whatever that might be to that particular individual, right? Health, wellness, fitness, whatever their fears are, we want to talk about those and allay those and change the course of their life. It doesn't matter who it is, right? So let's think about that every day. Like, every patient we encounter, every conversation we might have with someone in the gym, like, what can I do for this person? How can I help them, right? So that's who we are, right? One team, one mission, just changing lives. That's all I got. Any questions or any thoughts?
I'm assuming, like, with thyroid hormone replacement, you talked about insulin, these people will increase their risk of developing diabetes or thyroid disorders for their whole life if they supplement.
Well, I don't know that we know for sure, right? We can look, in the model that I always go to is like the woman who has been on birth control pills for a while, right? And they've suppressed their pituitary and hypothalamus by taking high dose estrogen and progesterone, right? And then when that woman then goes off those, over time, they usually ovulate again, right? It kicks back in. So, I mean, I think unless they have something like Hashimoto's thyroiditis that eroded their whole thyroid, if they take thyroid hormone and suppress it, when they go off, they're eventually going to, own supply will kick back in. It's just how long, you know? With like the insulin, yes, like they're not going to have to produce as much. And they also might also add a bunch of body fat while they're doing it, which could increase their risk. You know, but I think some of it's unknown, right? I mean, there's not a ton of studies at this, but just from our own clinical experience, I think, you know, the longer someone's on something, the bigger risk of it causing permanent dysfunction is. But you know, I think that's why it's a case-by-case basis. You know, like if someone came in and they've been on prednisone for Crohn's disease for a year or something, right? Like, we would slowly taper them off and see what happened. I think you might do the same approach if someone came in who'd been on self-administering 175 micrograms of T4. You know, you might just say, okay, let's slowly decrease this and see what happens. So.
I think it's important to note that graph of benefits and risks of the testosterone, that was the level drawn by the lab, not the dose.
Correct. That's the blood level, right? So like, that's a good point, because I might give Bill 200 milligrams of testosterone, which makes his blood level 900, right? I might get Josh 200, and it makes his blood level 1500, and Joe's, maybe it only makes it 300, right? So the dose we give is not necessarily the blood value. You know, we always pick a dose and check it and set the dose based on the blood value we see. So I usually like to give it about a month or so to reach steady state, right? And then you're good checking it. But then for something where you give a shot, we like to usually check the trough level. Trough level being right before the next dose. Like if you're doing it on, say, 7 days, it's like day 7 before you give this dose. Then I know the lowest level that you ever hit, and I know that you're going to always be above that. I won't necessarily know what your peak is, but at least I know where your low point is.
The other thing on that is just a small change in the dose causes the level to
You really can, right? Like you go from 200 to 220, and it might make your level go from 700 to 1200 or something like that. I think that's what Joe might be trying to say there. What you got, Big Dean?
anecdotally, particularly with football athletes, the thing I've always heard is that say you do HGH or another kind of anabolic steroid, that your muscles grow at a rate to which your ligaments and tendons can't catch up to. Would you say that's true?
Yeah, I do. And I think sometimes, even without anabolic steroids, like they in growth hormone, I think enhance this. But if I think we see this sometimes, like say someone's like, I'm going to start running or I'm going to start squatting, right? Their heart and lungs adapt really fast to that, few weeks, maybe a month, right? The muscles, few months, they develop the capacity. Those soft tissues take a lot longer to build up the strength they need to support that. So it does increase risk of injury. And I think taking growth hormone and testosterone, all of a sudden, if like now you've gone from a squat of 450 to 650, right? Like that's probably going to increase your risk of injury if you're doing explosive movements.
Yeah, I think that's the thing on like some of those slides where it says that it like increases tendon healing. Well, to a point, right? Like if you stress the load too much, we're gonna end up seeing a lot more tendinopathies that end up tearing.
Yeah.
So
And
there's definitely a lot more like physiological downsides, especially after a prolonged period of time using them.
yeah, that's a good point. I hadn't thought about that from a physical therapy standpoint, but yeah, that's what my thought is. Like you're just taking a lot of risks and unknowns. So to me, it's like I respect wanting to accomplish something, right? So start off with make sure you're putting in the hard work, that your workouts are efficient, that your nutrition's efficient, that you're sleeping right, that you're doing all the right things, your recovery modalities are right. Because I see so many people that are just starting to train and they're putting half-ass workouts, half-ass diets, and then they take some gear and they expect they're going to look like Ronnie Coleman, and that's just not the way it works, so.
I have another question.
Sure.
Are you generally skeptical on studies that are not on humans? Like I read a study about isometrics effect on tendon stiffness. Essentially, it was just a rat's tendon removed from the body, and they stretched it, and then kind of saw the effects of the stiffness afterwards, absent of like tendon resistance and all these other kinds of stuff that you're talking about. So after I read that, I'm kind of thinking like, is that a realistic way to?
Sarah and Josh, you probably have some good input on that too. But for me, anything that wasn't done on a human, to me, it's like maybe, right? That might translate, but it's also taken out of context, right? So like that, you remove a tendon, even if I took a dead person and removed their quad tendon, for example, and stretched it and did some tests on that, well, how's that going to translate to an actual sport? I think it's a stretch. You got to be careful drawing too many conclusions from things like that. So.
Well, and there's like more and more studies on tendinopathies and like how we rehab them at this point, right? So it used to be eccentrics, eccentrics, eccentrics. Now it's really the combination of what patients can tolerate, right? Between a eccentric, isometric, or isotonic, right? It's really the combination, and depending on the specific patient, that's why you have to really like do it like case by case for that patient, because some people may not be able to tolerate an isometric that might actually make them more irritated, or an eccentric might be too much, so it really just depends. But there's a lot more research now in humans that we've done from like the rehab side.
All right, well, I guess we'll call it a day. Thanks for coming. Really, really appreciate this. I'm really excited about this. Next week, Anthony Schlegel's talking. I believe it's going to be something along the lines of small unit cohesion, the power of the unit, something along those lines. So look forward to seeing you all then.